Today we are going to continue airway clearance therapy and talk about guided cough, PEP, and oscillation. So remember, airway clearance therapy is assisting patients with mobilizing and removing secretions. So we will start with guided cough. What are some disease processes that require airway clearance therapy? Cystic fibrosis, bronchiectasis, ciliary dyskinetic syndrome, and neuromuscular disease. And then some negative effects of retained secretion or some causes some issues that retained secretions cause are mucus plugging, full or partial obstruction, atelectasis, increased in airway resistance, increased risk of infection. So remember, it's important to remember why we are doing the guided cough or airway clearance therapy. These are some indications via the AARC. CPG stands for Clinical Practice Guidelines. So the AARC comes up with these clinical practice guidelines, and they include indications, contraindications, step by step on how to do processes or therapies or treatments. So if you ever forget, you're out of the hospital and you're like, "Ugh, I don't remember that from Therapeutics 2 a long time ago," you can go to the AARC's website and they have them all listed and posted. Okay, so some indications for directed cough specifically. So we're specifically talking about directed cough right now. Would be the removal of retained secretions, atelectasis, post-operative. So we're going to encourage them to cough because remember, they may be on narcotics or opiates. They may have just come out of anesthesia. So their cilia aren't working correctly. They're not woken up yet, or they hurt and they don't want to cough. So we're going to cough with them and kind of make them cough, force them to cough. It can be part of routine bronchial hygiene, like cystic fibrosis, bronchiectasis. Patients with chronic bronchitis definitely benefit from directed cough. And then we can combine it with other bronchial hygiene therapies. So we're going to start working on putting the pieces together. We're going to work on, okay, they have a small volume neb and they do their best, and then I'm going to make them cough. So we're going to start to pull pieces together and how we can efficiently put therapies with each other to get the best patient outcome that we can. So contraindications. So these are relative. So remember, so these are relative. And with contraindications, you have two types. So you have relative and absolute. So relative means, yeah, it's probably not a good idea with certain things that we should do this, but do the benefits outweigh the risks. So that's what relative. And remember, absolute means don't you even think about doing this therapy. It's absolutely not safe for the patient to do it. There's no outweighing the pros and cons. Okay. So contraindications. So infection, yes, an infection may be an indication if they have a pneumonia. When it says contraindication is infection, we're worried about those aerosol particles and the caregiver getting them. So if you have a COVID-19 patient, you're not going to give directed coughs. You're not going to work with them on coughing. Tuberculosis, if you're getting a sputum sample, you're going to want to cough it up and out. So remember, they're relative. So with TB, you're not necessarily every patient you want them to cough and get it up and out. If you want a sputum sample from a TB patient, yeah, you're going to want them to cough so you can get that sample, or a suspected TB patient, I should say. If they have an increased ICP or an intracranial aneurysm, if they are having major issues and you're afraid they're going to be intubated on the vent, if they cannot get these secretions up and out because there's a lot of mucus plugging, then you're going to watch and make sure that they're not straining, that they're not going to increase their ICP to a place where it can hurt them. If they have an unstable head, neck, or spine injury, if they just get so into that cough and they start violently coughing and they can do more damage, then no, you're probably not going to do a guided cough with them. If it's just a rule out neck injury, or the neurologist says, hey, we really need to do some sort of therapy to get this moving so he doesn't get a pneumonia, then you can go ahead with the directed cough. Okay, some side notes for directed cough. So patients who are obtunded, paralyzed, or uncooperative, you're not going to be able to do a directed cough with them. If they're obtunded, they can't even understand what you're saying, so they're not going to follow directions. If they're paralyzed, they may have that weaker diaphragm, and we'll get into some better therapies in a little bit that they can do to help remove those secretions. If they're uncooperative and they're just screaming at you, you're wasting your breath. You can try and explain to them the importance of not having those secretions in their lungs. Hey, Mr. Smith, this may cause a pneumonia, and I really don't want you to get any sicker than you already are. You might get the middle finger and a big FU. It's going to happen. You're going to have those patients, but you can try and explain why it's important and why it's there. And then always, even if they're the meanest, grumpiest old man that you ever met, you can just say, okay, well, if you change your mind, have your nurse call respiratory. Or the next day you can pop in and check on him, because the next day he may be a totally different guy. Maybe he couldn't eat anything all day because he had surgery that morning. So there may be factors. Don't just give up on your patients. Okay, off my soapbox. All right, teaching is critical in order for the directed cough to work. Teaching is critical. We need to be good teachers with everything we do, but directed cough is especially important. You need to be mindful of the patient's positioning. So if they're slumped over and they're holding onto a pillow and they're falling asleep and their head's down, that's probably not a good position. You want them to sit straight up or as straight as they can. If they can't sit up in a chair or on the edge of their bed, lift their back of their bed up as far as the patient is comfortable. We want them to get up and we want them to cough, but we don't want to cause them more pain. And depending on the disease or the operation, the technique can be modified. So depending on the disease or operation, we can modify it. Okay. Neuromuscular disease might require some other adjuncts that we can use with them. So teaching an effective cough. So we're going to say teaching here. One, they need to be in the proper position. So they need to be sitting up, their feet need to be supported. And then if the patient is unable to sit, remember we want the head of the bed up. And then we want the feet braced on the mattress. So that's just sitting up and then making sure their feet are stable, that they're not hanging off the side. And then 2 is breathing control. So we want to have an effective inspiration, compression, and expulsion phases. So we are going to control that irritation. We are going to make them cough. So we want them to have an effective inspiration, compression, and expulsion phase. So we want a slow, deep breath in through the nose. And we want them to use their diaphragm. And we are going to go into more of this on the next slide. So first, we're going to talk about the standard directed cough, because there are many different coughs that you're going to learn about. So, like I said, start in the sitting position, head of the bed up. We're going to do the inspiration phase. We're going to inhale slowly and deeply through the nose. Do it with me. So next, we're going to breathe in through the nose this time, and we're going to bear down on the glottis. So that's forcing that compression phase. So it's going to close the glottis so that we can cough. So inhale slowly and deep through your nose. And then you're going to force that cough. And you're going to demonstrate it for your patient. I wish we were in the classroom so I could demonstrate it besides just talking to you. But make sure to watch the resource videos. So it's always important to first demonstrate for your patient and then do it with them and then have them do it one time on their own. So some modifications. We have COPD. So we want to do pursed lip breathing and diaphragmatic breathing. Post-op, we will do splinting. For splinting, we are going to use a pillow and hold it against that incision. So this is good for teaching your patients who have had cardiac surgery or abdominal surgery to hold against that incision. And if they hold it tight when they're coughing, it's going to decrease that pain. And then neuromuscular patients, because they have a weak diaphragm, we are going to use a mechanical insufflation, exsufflation, or a quad cough. The next kind of cough we are going to go over is the forced expiratory technique. It's also known as the huff cough. It consists of 1 or 2 forced expirations at low to middle lung volumes, and you're going to keep the glottis open. So instead of getting that compression phase, you're going to keep the glottis open. So this will decrease changes in pleural pressure. Therefore, it'll decrease the likelihood of bronchial collapse. So studies show that this is good for patients who are prone to airway collapse. Can you think of a few diseases that are prone to airway collapse? Okay, so this would be good for CF, COPD, and bronchiectasis. So what the huff cough is for, it's going to help increase the sputum production that is able to be removed. It's going to help force it to those larger airways and up and out. So this is especially helpful when you have a patient who does CPT, postural drainage, the vest, anything like that. PEP therapy, which we will go over, and you can teach them to huff cough, or if they feel, so COPD, CF, and bronchiectasis. So you think of those large, kind of floppier airways. Some CFers have bronchiectasis on top of CF. And so those airways aren't as elastic as they were. So mucus is going to pool in their airways more than a patient with normal airways. So the huff cough is decreasing that pleural pressure, so it leaves those airways open. So when they huff, they can pull it up and out. Make sure that you go back through to this PowerPoint that I post and you watch all of these videos because they are going to give you step-by-step instructions on how to do these coughs. So here you have 2 different versions of huff coughs and then a post-op on teaching you how to splint. Some little tips that we give for huff coughing is you can say, hold your hand out like you are going to fog up a mirror. And you go, like you're going to steam up a mirror and you can feel that breath come out. That's a good terminology because a lot of times if you say, keep your glottis open, they're going to look at you like you just told them to do something really dirty. So remember when teaching your patients things, terminology is key. And I promise it's going to be rough at first, but I promise you'll come up for what works best for you. When I was referring to alveoli with my patients, a lot of times I would just call them the little air sacs. And they would understand more of what I was saying rather than saying alveoli. So I want you to practice your huff coughs and your splinting because not this week, but next week on our Zoom call, I want to see you guys practice it. Okay, a manually assisted cough. These are going to be for our neuromuscular patients. So these are going to be for our quads and paraplegics. So they do not have a strong enough cough and may require assistance. So that is where we are going to choose from these three options. So know these three options. We can suction them, whether it's through a trach or NT through the nose. We can do a manually assisted cough. So remember, manual is something where we use our body. A mechanical would be using a machine. So we can manually help them cough. We can do mechanical insufflation, exsufflation. With a manual assisted cough, it's us, the RTs, that are going to apply pressure to assist the patient to cough. So the patient's going to take a deep breath in, as big as they can. Remember, it's not going to be as deep as our breaths or as your other patient's breaths. So tell them as deep as they can. And then the patient's going to try and generate a cough. While they still might have a cough, it may be very weak, which is why you need to help them. And then as they cough, you're going to apply pressure to the lateral costal margins. So right underneath their rib cage by their diaphragm, you're going to push it up towards them. So again, go back and watch this video. This is a good example on how to do a manually assisted cough. You may also hear them referred to as quad coughs. So watch this video. Should you do this on pregnant patients? No, no pregnant patients. Should you do this on someone with flail chest? No. Should you do this on someone who is unconscious? No. So not for pregnant patients, patients with flail chest, or if your patient is unconscious. They need to be somewhat with it. Okay. This is not something that you're going to have to do for a lab checkoff. You should practice. If you have someone you can practice, or practice with a pillow or a stuffed animal. But know that if you're doing it on a person, a family member, that they have good abdominal muscles, so you're not going to be able to feel how hard you should push, because you're not going to need to push as much as a patient who has a neuromuscular disease. This is really commonly used at Craig Hospital. So active cycle breathing is used to loosen the secretions from different areas in the lungs and be able to cough them out. So this is something that you could put with PEP therapy, with postural drainage, a directed cough. You should perform huff coughs if you're able to when you're doing this. It is not ideal for children less than 2 years or critically ill. Critically ill. So what this one does is you're going to relax and start with normal breathing. You can do 3 to 4 thoracic expansion exercises. So make sure that your patient is sitting up straight with their feet planted on the floor or the head of the bed up. So 3 or 4 thoracic expansion exercises, and then you're going to relax and breathe normal again. And then again, 3 or 4 thoracic expansion exercises, back to regular breathing, and then 2 huff coughs, because that's going to open the different areas of your lungs, and it's going to help. Those big exercises are going to help pull that mucus down. This is a great video They do a very good job of showing how to teach somebody how to do it. And then also, since you're just learning, they do a great job of explaining it. You can't see me right now, um, so I want you to go back and watch these videos, and I want you guys to practice doing this. So this is great for someone with COPD, someone with pneumonia, anyone who's sick. This is a pretty easy one to do for any type of secretion retention. So autogenic drainage can be a little bit trickier. This is more common in patients who have copious secretions all the time, who are always constantly working on their airway clearance therapy. CF, this is a huge one for CF and chronic bronchitis. So it's using diaphragmatic breathing, and that's how we're going to get the secretions to be mobilized. It uses 3 distinct phases, which varies in lung volumes and expiratory flows. The patient should be in a sitting position. That's important to know. Sitting position. And coughing should be suppressed until all 3 phases are complete. Okay, so this is just a visual of autogenic draining. So phases 1, 2, and 3. These 3 phases are what's going to mobilize secretions. So we'll start over here, normal. So we have normal tidal breathing. Deep breath out as fast or as far as you can, and then that's all the way full, and then back to tidal volume. So that's normal. So with autogenic draining, you're going to breathe deep out till you feel like your lungs are totally empty. And then you're going to breathe all the way in till they're totally full, and then almost all the way out, and then almost tidal volume. And you're just going to keep following this for a few breaths. And then you're going to breathe just a little bit more in till the middle of your lungs, the middle of capacity, and keep increasing it. Keep increasing it until you get almost till total volume. So what this is going to do until you practice it, I want you to practice it so you can feel it, because it works. If you're sick and you have a cold, you can do any of these coughs and it's going to help you feel so much better. If you have allergies and you just feel like you've got a lot of nasty mucus in there, try some of these coughing exercises. It will help you, I promise. So, with CFers or patients who have asthma, I've become aware because I'm an RT and because of Maryland, I can start to feel where I feel more plugged up with my allergies. And when my asthma is really bothering me, I can feel the secretions and where I need to really focus. What area? Is it down in the bases? Is it more towards the middle? And so if you do the autogenic drainage, it's going to help you. I will say it again, watch these videos. They are so great. They're good resources. Here we have 2 ways to modify guided cough and breathing techniques for COPD. So this is important to know. So know this could be on a test. So know. So if you have a patient who has a history of COPD and they have chronic bronchitis and you're asked what kind of guided techniques might you suggest, you could suggest diaphragmatic breathing or pursed lip breathing on top of the huff cough. So diaphragmatic breathing is going to encourage using the abdominal muscles to help pull that diaphragm down and out so that they can get a bigger, deeper breath. Pursed lip breathing, the patient is going to take a deep breath in through their nose and then exhale through pursed lips, so like they're blowing a kiss or blowing out birthday candles. This is going to narrow the airway, so it's going to create that back pressure to help split those airways open to prevent air trapping. Mechanical insufflation exsufflation, or MIE, is what we're going to use on our neuromuscular patients or our paraplegic, quadriplegic patients. We can use a mask or an artificial airway. So this can also be used on patients who are on the ventilator and have an ET tube and they can't generate a cough. Or we think they have secretions way deep down in their bases and the suction catheter can't get to it. So we can hook them up to insufflation, exsufflation and help move those secretions because this is still delivering pressure and oxygen. It's still going to let them give their volumes. So we can use a mask or artificial airway. The newer units have oscillation, and that's going to help shake from the inside on inspiration and expiration. So what it does is it delivers a positive pressure breath first, so inspiration of 30 to 50 centimeters of water pressure for about 1 to 3 seconds. And then abruptly, it's going to suck it out. So on expiration, it's going to reverse that pressure. So it's going to have a negative pressure of negative 30 to negative 50 centimeters of water pressure for 2 to 3 seconds. So know these pressures for inspiration and expiration. And then also note 1 to 3 for inspiration and 2 to 3 for expiration. So it's keeping a normal I to E ratio or normal-ish. Treatment sessions you should typically only do for 5 cycles and then allow them to catch their breath. Let them have normal spontaneous breathing. If they cough something up and you have a yank hour, and you can just suction it out of their mouth. So a note, with neuromuscular patients, they cannot generate a peak cough flow greater than 180 liters a minute. So they may benefit from the mechanical insufflator exsufflator. Um, and the peak cough flow is measured with peak flow meters and spirometers. Okay, so this is an older unit by Philips Respironics, and this is an MIE. You can see the mask here, or it attaches, you can take the mask off and it attaches directly to the trach or to the endotracheal tube. And it's hard to see in this picture, but you have your settings on this side, and it's gonna give a pause, and you can set your pressures or how many seconds. And then you flip the switch back and forth. So this is exhale, this is inhale. So you can set it so it runs automatically, and that's what these knobs are for. So it's saying, okay, we want to inhale for 2 seconds and exhale for 3 seconds, or inhale for 1 second, exhale for 3. So it'll automatically go from inhalation to exhalation, or with this little knob here, if you get to know your patient and you can hear their secretions and you get used to it, you can do it manually as well. I used this machine at St. Anthony's. We had a patient who had ALS, and so he had a really weak diaphragm, and he loved his insufflation exhalation machine, and we would go in there. He wanted us to wake him up every 4 hours throughout the night, and we do it for 5 breaths, and he just wanted us to keep going and going and going. So it's important to also let your patients know, hey, you need to take a break. Let's take a few breaths first, let's calm down, and then we can do it again. And sometimes they just think that there may be more secretions in their lungs, and there may not be, or we may be stimulating more production of secretions. Okay, so this video shows how insufflator exsufflator is used. This is a newer insufflator exsufflator. This one also acts as suction, and I believe this one has oscillation as well. So I wanted to point out a few things in this picture right here before you guys watch the video. So you notice you have the trach mask here, or trach collar. He has a trach, and that insufflator exsufflation machine is going to hook up right to the trach. So he can cough it up, and it can either come out the trach, or if the balloon is down, it can come out of his mouth too. So we are moving on to positive pressure adjuncts. What patient population would benefit from a device with hyperinflation, so adding that pressure and inflating the lungs, and mobilizing secretions? Post-op patients, because remember, in the OR, they are under anesthesia, so they're under those drugs which inhibit the mucociliary escalator. They are also taking smaller tidal volumes, so that's the hyperinflation part, and we're helping them move their secretions. So we're going to help prevent atelectasis. This can be used with other airway clearance techniques, so postural drainage, CPT, the vest, PEP therapy, all of those. So some contraindications: hemodynamic instability. So this is classes when you're going to start hearing more about the squishy squish. So what the squishy squish is your lungs around your heart. So if we're adding too much pressure and a lot of pressure, we can squish that heart and it's not going to be able to expand and squeeze enough blood volume. We're not as worried about it with like easy PEP, which is what we're talking about here. That is going to happen more with BiPAP, CPAP on the ventilator. So hemodynamic instability for this, if you're in the cardiac ICU, they're probably going to order EasyPAP. If your patient can't get their blood pressure under control, whether they're hypertensive or hypotensive, especially hypotensive, you might let the nurse do her magic and get it under control before you do their EasyPAP. ICP, because if they're straining and they're blowing against continuous pressure, it can increase their intracranial pressure and cause more damage. Hemodynamic instability is on there twice. Active hemoptysis and untreated pneumo. Pretty much, if you want to know the contraindication for something, untreated pneumo is always a safe bet if it's a question. Recent facial, oral, or skull trauma. If they can't make a good seal, or it's going to cause them pain or cause more damage to what they have done, then it's not worth the risk. If they have a nosebleed, if they're on esophageal suction, so if they have an NG tube in their stomach and they're actively pulling stuff out, you don't want to risk aspirating. If they accidentally move that NG tube and it comes out and they aspirate into their lungs, then we're just making them worse than they already are. And nausea. We don't want them to aspirate and develop a pneumonia. It can cause barotrauma, especially if they have a history of pneumos or they have one that's untreated that you don't see in a chest x-ray, hasn't been diagnosed. It can increase ICP, air swallowing, vomiting, and aspiration. Claustrophobia, depending on what they use, and then increased work of breathing. PEP therapy. PEP therapy is a very important tool. It can be used for all kinds of different patients. It was one of my favorite tools to use when I was on the floor. If someone was like, oh, I just feel so junky and I just can't get it up. Or sometimes when you're talking to a patient while they're doing a neb and you can hear the rattle, a lot of your job is going to be by what you hear. So you can hear a rattle or you hear a loose cough. Grab a PEP device, whatever your hospital uses, and teach them how to properly use it. And you can just set it by the bedside table and instruct them how to properly use it, and they'll do so much better. So what they're doing though is they are blowing against a flow resistance. So they're creating back pressure, and it can be fixed or it can be varied depending on the device. So it's going to create pressures, a back pressure of 10 to 20 centimeters of water pressure. So when they're blowing out into the device, it's creating a pressure that they have to blow against, which is going to force those airways open. So vibratory PEP is going to also provide rapid fluctuations in airway pressure. So instead of that consistent pressure, like easy PAP or positive expiratory pressure, it's going to be a expiratory pressure and resistance, but is also going to add a vibration to it. So that's not only are they getting that resistance to open up those airways, but those frequency and vibrations are going to help pull that mucus off of the alveoli and pull it off the alveoli walls. Do's and don'ts. Do's. CF and COPD patients. Use it in line with nebulizers. It is great when you can pop it in line, especially instead of doing your 10-15 minute nebulizer treatment and then you're spending 10 minutes, 5 to 10 minutes doing the easy PAP or VibraPEP. Pop that sucker in line with the neb and you're 2 for 1. They might have to take breaks. You might have to adjust it so that they don't increase their work of breathing, but it's a great tool. Do use it 2 to 4 times a day. So something that I would tell my patients, especially if you feel like little old Granny Smith needs you to check on her every 4 hours to make sure that she's doing it, or every 6 hours, you can schedule that if you have respiratory protocol and someone can go see her every 6 hours to instruct her how to do it and make sure she's doing it. If you have a patient and you're in there with their treatment and they're fine and they remember how to do it and they show you how to do it properly, you can teach them how to do it once. You can say, okay, I'm going to set this on the table right next to you, your bedside table or your nightstand, and once an hour, every couple hours, if they're watching TV, you can say during commercial breaks, how about you do a couple breaths? You don't want to do more than 10 breaths per time they do it because we don't want to tire them out, blowing against that airway resistance. Okay, some don'ts. Don't use it with children less than 3. They're not able to have the proper technique for it to work. When someone's doing a VibraPEP or doing an acapella or an aerobica, they need to be able to keep their cheeks in so they don't puff out like chipmunks. Otherwise, they're losing all the vibration and that back pressure into their cheeks, so it's not going to work. Don't use it for post-op atelectasis. We're going to want them to take bigger, deeper breaths. So when easy PAP, so positive airway pressure, or we want them to use a metaneb, or they can use an inspiratory spirometer, an IS. This isn't going to create enough back pressure to pop open the alveoli if they already have atelectasis. If patients cannot take a deep breath or tire out too easy, this is not good for them. It requires more energy. So these are some different PEP devices. So you have the acapella, you have the Rebica, and the VibraPEP. This is a different easy PEP device that doesn't connect to oxygen tubing. And this one is a flutter valve. Okay, so this is the easy PEP. Go and watch the video online. It's a great device. What it does is it hooks up to oxygen or air, depending on what is available in the patient's room. It will generate a flow, a back pressure that the patient will exhale against. So easy PAP, so PAP, positive airway pressure. So it's giving you a continuous flow. And depending on what you set the resistance at, will increase or decrease that back pressure that they are exhaling against. And since they have to overcome that pressure to exhale, it'll help pop those lower airways open. Okay, the acapella. So this video says it's good for atelectasis. According to the MBRC, I would not choose an acapella as the go-to for atelectasis. I would rather do directed cough or the IS or the easy PEP. But the The acapella is great for COPD and chronic bronchitis. It's good for bronchiectasis, CF, asthma, anything where there's a lot of secretions. So here's an example of Marilyn with her, she's like our tea dream right here. So you have the vest, and then she has her breath enhanced neb, and she has the VibraPep. So she loves the VibraPep. It's easy to clean. You can take it apart, throw it in the top rack of the dishwasher, clean it in vinegar, the same kind of way you clean the nebulizer cup. I got that for her from St. Anthony's. Children's CF clinic use the acapella. They're in the process of switching to the VibraPep because her pulmonologist listened to Marilyn and that she liked the, the VibraPep and she could actually get up sputum samples for him with that. So I'm not biased or anything. I just prefer the VibraPep. But if you notice in this picture, she has her cheeks puffed out like a chipmunk. So we have worked on it and she is much better. She is probably 4.5 or 5 in this picture. So she was still working on her technique. So high frequency compression and oscillation. So that's a technical term for the vest. So it's applied externally over the chest wall. The vest systems are going to inflate and deflate. So it's creating different pressures and pulses. It's also going to vibrate at the same time. So it's vibrating and creating different pressures to help knock that mucus down and into the larger airways. So you'll commonly see Hillrom, the vest, and Monarch. Monarch is their version of a hoseless system. Electromed, which is the smart vest, it only has one hose. Respiratech, their vest is called the Encourage vest. And then AffloVest, which is the one that you have seen in 5 Feet Apart. And it's a hoseless vest. It's battery operated. It's the one Marilyn currently has that she loves. Vests are amazing and they do great things, but your patient must be actively involved in their treatments. If they just sit there and they don't want to huff cough afterwards or take their treatments or do anything to help themselves with these vests, then it's useless. So your patient has to want to do it. That's with all of these therapies. Your patient has to actively try and you have to give them good education. Otherwise, it's not going to be worth it. Okay, so I encourage you to go back and watch this video. This is Morgan Grindstaff. He's got some funny videos as well. He has CF, and he's a big CF advocate, and he just kind of reviews the vest and how he likes it. Another way that we can produce high frequency compression and oscillation is through airway application via the metaneb or intrapulmonary percussive ventilation. So IPV and then metaneb. So IPV isn't used as often anymore. It was more commonly used at Children's University. You can put both of these, you can put in line with the vent. They're both pneumatic devices and they deliver little bursts of gas. And that's going to create the compression and oscillation as they exhale through that pressure resistance. And it can also deliver aerosolized medication. So this is great for your CFers because not only are they getting their medication that takes forever, the whole time they're doing their meds, they're also getting this oscillation and this change in pressures from the device that's giving them their meds. It's more common in older children who can do the treatment properly. Okay, so you have your IPV machine here. You can set your percussion here and then your pressure here. And this is going to tell you the source pressure on what you're giving, and then what pressures they are getting in their lungs on expiration. Here is the metaneb. This is more common now. We have one at the school that we can try when we get back to campus. So you're going to do 2.5 minutes on CPEP, so continuous positive expiratory pressure, and that's going to cause the lungs to expand. So that's just exhaling against a continuous pressure. So the pressure remains the same. And then for 2.5 minutes, then that's when they're going to add oscillation. It's going to help secretion clearance. And then they're going to switch to lung expansion again. So it's just going to be a continuous pressure and then back to oscillation. It's a really easy machine to use. You've got the circuits here. It just clicks in. It's not as difficult to set up as the IPV. And then you can change, adjust the dial. So you have just the continuous pressure here and oscillation here, continuous pressure here. For oscillation, you can choose being the lowest amount of vibration and oscillation down here, and you can dial it up to the highest amount. So you choose here, and then you're going to choose what flow you want for your pressure. So the lower the flow, the easier it is to breathe and exhale through that back continuous pressure. The higher the flow and the pressure, the harder it is going to be to exhale, and it's going to cause those lungs to splint open. Physical activity is something, and exercise is something that we should be recommending to all of our patients. It can increase tidal volume. Think about it. If you're exercising, you're walking up a big hill, you're going on a hike, your body's increasing metabolic demands. So your body's going to compensate for that by taking big, deep breaths, filling the lungs as much as they can. That's going to decrease atelectasis. It's going to increase the heart rate, so it's getting that oxygen to the tissues as it's needed, which is increasing cardiac output, and overall their physical condition is going to be better. They like to recommend exercise for CFers all the time. If you think about it, someone who has lots of secretions and they're very active, they're breathing deeper, they're going to cough. It's going to move that secretion. It's going to be constantly mobile. Even when we're in the hospital, we can ask our patients if they're not a fall risk. Hey, did you get up and go walk around the floor today? Have you gotten up out of bed? Because if they're just laying in bed, they're taking those smaller tidal volumes. We want them to open up their entire lung down to the bases. Plus, it helps reduce the risk of blood clots. We don't want them just laying in bed and not being mobile. Some critical thinking. A 19-year-old CF patient is preparing to move away for college. At home, the patient has been receiving postural drainage and percussion at least twice per day. Which of the following will be suitable for the patient when away from home? So here, PEP therapy would be the most accurate response. She should be already taking portable neb treatments. She still has to do her nebs. Yeah, right. Are you going to ask your roommate at college to do chest percussion therapy? Probably not going to happen. And home health practitioners for percussion daily, that would be so expensive. Not to mention, there's already a stigma about having CF and moving to college and wanting to be independent and out of the house. They don't want to draw more attention to themselves. So the best answer here would be PEP therapy. If she has a portable vest, she could do that. Since they've been doing postural drainage and percussion at home, she might talk to her care team about getting a vest, but PEP therapy would work as well. While training a patient to perform PEP therapy, the RT notices sudden development of rhonchi, followed by an episode of vigorous coughing. The therapist should continue therapy, halt therapy, and consider switching to another clearance technique, lay the patient in supine position for several minutes, or re-instruct the patient on better technique. So the RT should continue therapy. Because they're coughing, they hear rhonchi, they're doing it correctly. They're moving that mucus so they can cough it up and out. Um, Remember, we don't want to lay the patient supine if they're coughing. If patients ever coughing, we want to sit them up.